Hi, this is Jean Deschamps from Université de Montréal. This video will be discussing the basic left ventricular views and assessment. For additional content, please refer to our website at sonouni.com or our YouTube channel at Sonovault. At the end of this video, you'll be able to understand the basic cardiac views, understand the basic left ventricular size evaluation, and understand basic left ventricular systolic function evaluation. Please note that we will not be going into details of LVEF assessment. You can refer to the 2D LVEF pitfalls for nuances of visual LV assessment. The different quantification methods will be covered in our more advanced LV assessment videos. I would like to encourage any learner to refer to the wonderful online app created by the University of Toronto. It is an interactive way to go through basic and more advanced cardiac echo views. You can find it by Googling Toronto TTE or following the link shown on this slide. We'll start with the full spectrum of views necessary for proper LV assessment. There are multiple areas where one needs to go to find all the necessary views for proper LV assessment. These shown on the slide are the more common ones. Please note that additional views can be obtained from right parasternal and transhepatic views as well as off-axis views. Remember that in a lot of patients, not all windows will be easily accessible. This is due to the heart position favoring a specific window at the expense of another. This is a summary of most helpful views for proper LV assessment, in a standard order as would be done in a cardiac echo lab. We are of course skipping views that are not focused on the LV in this instance. For the early learners, you can do a fairly comprehensive assessment using the views that are not grayed out and boxed in. Those views that are grayed out and boxed in are additional views that are very helpful for more nuanced assessment. As you go through the rest of the videos, these views will come into use. In a sequence, most echocardiographers will start with a parasternal view. The parasternal views will give you a large overview of most of the heart and hints of what is to come. The area of interest is obviously parasternal, but can expand quite a few centimeters away from the sternum in a number of instances. It ranges from the second to the 4th or 5th intercostal space. The best interspace depends largely on the patient's condition. In general, tall and skinny individuals tend to have hearts in a more vertical position. Thus, having a probe closer to the sternum is more helpful. Ventilated patients tend to have more difficult parasternals as the heart is squished midline and pushed down in the lower intercostal spaces. There are two parasternal LV views, the parasternal long axis view and the parasternal short axis view. These two views are orthogonal to one another. You can obtain the parasternal long axis view by finding a view in the parasternal zone on the chest and rotating the probe towards the right shoulder of the patient. This is a general guide, and individual patients will require some adjustments to obtain the view. The parasternal short axis view is obtained by doing a clockwise 90-degree rotation, moving from longitudinal LV to cross-sectional LV. One trick to find the best intercostal space is to start pretty high, under the clavicle, and progressively scan every intercostal space down. Once you have one with a view, go one further to check if the lower one is better. I can't tell you how many times I've struggled with one intercostal space while the view is optimal slightly lower. The parasternal long axis view is the first obtained in any echocardiogram. This view is one of the most complete views in terms of hinting to abnormalities. You can see both ventricles, the LA, both the aortic valve and mitral valve, and it covers about 3 coronary territories through the LV and RV walls displayed. Standardization of this view is as follows. The apex should be barely visible. The LV should be as elongated as possible. The RVOT should be visible without any tricuspid valve. The valves both need to be visible. The 2 aortic valve cuffs should be of equal length and closing in the middle of the root. Finally, the 2 mitral leaflets should be separating during diastole, but cannot of course be of equal length by simple morphology. This is a poorly aligned parasternal long axis view of the same patient. The LV appears to be foreshortened with the infralateral wall actually moving in rather than simply contracting. The aortic valve is not closing in the middle of the LVOT. However, the valves are both visible. Essentially, the LV is rounder than it should be. This is usually a matter of the probe being in the wrong intercostal space. Changing intercostal space will elongate the LV, but will likely require some rotation to realign the valves. Usually, if the LV is well aligned, but the valves are not both visible, a simple rotation will fix this issue. The parasternal short axis view is a useful view for gross LV systolic function, with the caveat that it only covers the mid portion of the LV. It is the most useful view for interventricular pressure differential assessment, also known as interventricular septal assessment. One will often be able to pick out posterior pericardial effusions, something particularly useful in post-op cardiac surgery patients that can have loculated effusions. Standardizing this view requires making the cavity as round as possible. Usually, it is difficult to get the full RV into view, and only part of it will wrap around the LV. The two papillary muscles should be seen and be of equal size, and finally, no part of the mitral valve should be visible. This is another example of a reasonably well-aligned and standardized parasternal short axis view. The RV is barely showing here, but the septum is in full sight. This would probably be considered overly acceptable. These are poorly aligned parasternal short axis views. You can see that both cavities are oblong rather than round. The mitral valve is showing in both and no papillary muscles are seen. This is both closer to the base and also cut at an angle. Proper correction is usually done by a combination of two movements. First, sliding towards the apex, and second, slightly fanning. This will displace the probe over the mid portion of the LV and cut the LV perpendicular to its long axis. Most adjustments in this view are done with this combination. If you're going through the additional views, you will notice that there are two additional parasternal short axis views relevant to LV assessment. Both are obtained by fanning through the LV, cutting cross-sections at different levels. This is a useful way to see the whole LV to assess for wall motion abnormalities. The first is the parasternal short axis at the mitral valve level. This is helpful for observing the anatomy of the mitral valve, particularly in mitral stenosis, where one can trace the area if using 3D guidance. One word of caution. In this view, the septal wall may look hypokinetic. This is because this is the start of the aortomitral curtain, formed mostly of fibrous material. The second view is the apical parasternal short axis view, helpful to better delineate clot if there is an apical akinesis. The coronary sinus can be seen as you get close to the base of the heart, and is often mistaken for an effusion. Differentiating it is quite simple. It will not progress much or at all past the junction between the two ventricles. The next set of views are usually the apical views. These form the backbone of LV assessment, particularly for function in regional wall motion abnormalities. These are performed by positioning the probe at the apex. This would correspond to the PMI on a physical exam. An easy way to transition to this point is to follow the apex from the parasternal long axis view and slide it down along its axis while maintaining vision of the LV. This point usually ranges between the 4th and 6th intercostal space with variable laterality, all of it depending on patient anatomy. Ventilated, tall, and skinny patients tend to have more medial views. From this point, you can obtain the three mainstays of the apical views. The apical 4-chamber view is obtained by having the patient's probe marker turned towards the patient's back, as in 90 degrees from the patient's long axis or their spine. From there, a 60-degree counterclockwise rotation to have the marker facing the left shoulder will give you the apical 2-chamber view. This usually requires some degree of slide translation and fanning to realign after the rotation. Finally, another 60 degrees rotation counterclockwise to have the marker facing the right shoulder will give you the apical 3-chamber view. These are named based on how many of each cardiac chambers are seen on the screen. Having all three views gives you a full appreciation of all cardiac walls, making LV systolic function and regional wall motion abnormalities assessment complete. The apical 4-chamber view is the basic view for budding echocardiographers. This view is most useful for overall generalized assessment of global biventricular function in atrial size. It also allows proper inspection of the mitral valve and tricuspid valve, as well as septal interactions. Standardization in this view requires having an LV apex that is not moving in space and only thickening. This thickening is usually lesser than the other walls. The LV will be elongated as much as possible. These two elements put together avoid foreshortening the LV. The most common mistake that causes a globular LV is being in the wrong intercostal space. Finally, the left atrium, RV, and right atrium are visible and expanded, while the LV outflow tract is not visible. The left atrium does not have to be at its longest size, as it often expands not in the same axis as the left ventricle. The right ventricle may not be entirely visible at all times, and this is commonly accepted as adequate. The apical two-chamber view is probably the hardest view to properly obtain, but critical for anterior wall assessment, which represents a large portion of the LAD territory and a big contributor to LV ejection fraction. Standardizing this view requires similar apical and length optimization as a four-chamber view. The mitral valve should be visible, ideally with the hanging leaflet. This means that we have two slits in the mitral valve, representing the posterior leaflet circling the tip of the anterior leaflet floating in the view. The coronary sinus and left atrial appendage help standardize and confirm the appropriate rotation further, but are not always seen. The apical three-chamber view is essentially a parasternal long axis view seen from the apex, with the obvious difference being a fully visible apex. As such, standardizing it is essentially the same as any apical view for the left ventricle and the parasternal long axis view for other structures. As you can see, a 3D probe can be extremely useful to get adequate alignment of all apical views. It would be ideal to always perform this with a 3D probe, but two issues prevent permanent replacement. First, it is of a large footprint, and second, its temporal resolution, also known as the frame per second, is less than a 2D probe due to technical factors related to 3D acquisition. You'll also notice that we don't always see all the structures in those views. This is because we will zoom in on the LV once properly aligned to get better visualization of the different walls for regional wall motion abnormalities. The subcostal view is usually the last set of views for a standard echocardiogram for LV assessment. This view is performed by putting the probe under the xiphoid and tilting or fanning until looking close under the sternum. This view is a lifesaver, as you can perform almost a full 2D structural echo from this position. However, it is limited in terms of standardized and Doppler measurements. This is usually easier in ventilated patients as the heart is pushed down into position. The subcostal four-chamber view has a bit of a unique movement to obtain. Rather than pushing down, one should perform a hook-like motion, like trying to hook the probe under the xiphoid. Of course, one is not pushing it completely under the xiphoid. In this position, the marker should be towards the left of the patient. You will see the liver in front of the four-chamber heart lying more parallel than the apical four-chamber on the screen. One trick to find the best location is to start about 1 to 2 centimeters below the ribcage, lateral to the midclavicular point, and then follow the ribcage midline. It is critical to understand that measurements cannot be performed in this view because there are no landmarks that can be used to avoid foreshortening of the cavities. Similarly, Doppler views are very hard to obtain except for the RV outflow tract VTI, is seen in a more advanced view. As described previously, a full structural echo can be performed from a subcostal view. This is done by using the same probe orientation as the IVC, usually with a slight clockwise rotation and simply fanning up and down perpendicular to the LV long axis. You will get a parasternal short axis view, as well as its other views as described previously. You can also obtain an RV outflow tract view from which you can perform an RV outflow tract VTI. We will now cover size measurement principles and basic visual function assessment. More advanced function assessment is covered in other videos. Size assessment is often grossly assessed. This is somewhat problematic because from a purely visual point of view, we have no structural comparators. Depending on how deep or wide the beam is, the LV may appear small or large. One has to look at the depth scale and guesstimate its dimensions. Unfortunately, this is often due in the apical view, which is harder to visually compare and not the standardized ASC guideline recommendations. Rather, we should take a few seconds and freeze an end diastolic and end systolic frame in the parasternal long axis view and properly measure the views. The ASC dictates this view for measurement based on the physics principles that use the better axial resolution for fine millimeter differences in wall thickness. The best way to identify diastole and systole is to look at valve opening. For end diastole, select the frame just before the aortic valve opens. For end systole, select the frame just before the mitral valve opens. At this point, measure the inner to inner wall measurement, staying perpendicular to the long axis of the ventricle. As noted above, the standard dimensions have been determined from large population studies. The numbers written here represent the highest 2 standard deviation for male and females. From there, you can also measure the posterior and septal wall using the specific LV mass index. Be careful to avoid pericardium, and on the septal side, take about 2/3 of the septum, as part of this wall is considered the right ventricle. LV systolic assessment of function can be tricky sometimes because we are looking at a 3D structure using 2D planes. Thankfully, the LV is pretty symmetrical in shape, making it easier to conceptualize. Overall, you need to think of it in terms of volume leaving a cavity, knowing that what happens in one plane is actually happening in a lot of directions. As such, what may appear like a small linear size reduction of the cavity actually represents a lot more volume than expected. Thankfully, we have some basic tricks to get a general idea of whether or not all the function is normal. The first trick is wall thickening. You need good endocardial definition to do this, which is not always possible. With heart contraction, the walls will thicken. Normally, all the walls thicken equally and synchronously. If all the walls are thickening well, this decreases the likelihood of a major LVEF depression. If complete segments are not thickening well or at all, this should clue you in that the LVEF may not be normal. Thickening of the walls is similar to having a biceps extended versus flexed. The number of fibers are the same, but they are now packed together and shorter. We expect somewhere along the 40 to 50% wall thickening to be considered normal. You can see here the obvious difference in size of the segments between diastole and systole. With increasing myocardial dysfunction, walls can become progressively apokinetic and akinetic. It is way easier to see difference between walls than something like global hypokinesis. I would always compare one wall to another. Even global hypokinesis is often not exactly that homogeneous. The hypokinesis shown here is quite severe, bordering on akinesis. The akinesis shown on the right is actually way past akinesis, with evidence of thinning suggestive of scar formation. With some experience, you will start noticing when something is thickening, but is not as springy as you usually see. These slight differences can help hint as a subnormal LVEF. The second part is to ask yourself if all the walls are thickening at the same time towards the middle. If they are synchronous, it is much easier to assess LVEF and cavity reduction. In some situations, such as dyskinesis or left middle branch block, one wall will move away while another is moving towards the cavity. This may look like a good EF, but it is actually only lateral movement of the heart. I would suggest, in doubt, to take a clip and slow it down to better assess this. Finally, you should divide a cavity. Simply put, hide the top or bottom part of the LV with your hand in an apical view. Then try to figure out what you think the LVEF, either grossly or numerically, is. Do the same for the other segments and then average them, putting a bit more emphasis on the base of the heart. This is because we are talking about radial measurement of a 3D structure, meaning everything is squared. As such, the lower half provides a lot more volume out than the upper half. As an example, if I see an LVEF of 40% in the upper half and 60% in the lower half, rather than say 50%, I would aim closer to 55. You can then do this in every apical view and average out the 3 apicals to get your overall EF. This is generally not as important in overall symmetrical LV, but in some situations this is downright essential. This example is a burnt out apical hypertrophic cardiomyopathy. As you can see, the mid-cavity is essentially collapsing in systole, while the apex does barely anything. However, remember that 100% of 10 is only 10, and that is what is happening in the mid-cavity. Meanwhile, 5% of 50 is 2.5. Overall, though, that is only 15 out of 60, which is not great. Ideally, you would do everything using 3D, but as discussed previously, there are technical factors that limit application. As you can see here, if you can do it though, you get a very good assessment of what the LV actually contracts like at every segment and every level. Grossly, you can categorize LVEF based on these big categories. The above clips give you some examples of different gross LVEFs. Once you have seen a couple, gross assessment becomes rapidly easy. I would venture that most people can rapidly call numerical LVEF. Where it becomes tricky is very precise assessment, particularly along 30 to 40% range, where there are cardiology management considerations such as ICDs. For most of us, though, this degree of differentiation is not essential. This is the end of this video on basic LVEF assessment. Please feel free to contact us through our Twitter accounts with any questions or comments, or through the Sonovault website and YouTube channel.